important announcement about scientific presentations. Category under UG papers. The venue is Skills Lab, second floor, B module, and the judges will be Dr. Lada Ravichandran ma'am and Dr. T. Mahati ma'am. Under the category E-posters, the venue will be MEU Hall, ground floor, B module, the same module, and the judges will be Dr. M. Kavita ma'am and Dr. P.J. Srinivas sir. And the PG papers, part 1. That AP Medigon ID I will tell, just 066 073 233 158 159 251 149 168 160 171 167 142. This is part 1, PG papers. That will be presented in Charaka Hall, second floor, same module. And the judges will be Dr. Margaret Shanti ma'am and Dr. Krishnamurthy sir. And the PG papers, part 2, and AP Medigon ID 144 204 166 266 139 151 181 182 190 033 180. And the venue will be in the Dhanvantri Hall, second floor, and the same module. And the judges will be Dr. Jagati Nagari ma'am and Dr. T. Lakshmi Lalita ma'am. And the next category, faculty paper, part 1, AP Medigon ID 080 175 219 207 057 214 006 049. It will be in the Yelapragada Hall, second floor, same module. And judges will be Dr. Sai Leela ma'am and Dr. Padmaja ma'am. And the paper category, faculty paper, part 2, AP Medigon ID 179 265 068 116 095 018 179 will be in Shushruda Hall, second floor, same module. And the judges will be Dr. Samson Sanjeeva Rao sir and Dr. G. Hima Bindu ma'am. And finally, category innovation papers, AP will be in the same hall, mini auditorium. And the judges will be Dr. Saravanan Sannyasi sir and Dr. D.S. Muthi sir. And all the scientific presentations will be starting at 4:30 p.m. in the respective venues. And all the volunteers of scientific presentation, please assemble now only in the respective halls.
Coming up, we have a session on the topic Assessment in a Simulated Environment. And the speaker for the session is Dr. John Stephen sir, Professor and Head of the Department Dermatology, Dr. Chandrama Dayananda Sagar Institute of Medical Education and Research, Director of Medical Education with 25 years of teaching experience, 15 years of medical education leadership, former convener NMC Nodal Center for Faculty Development Member, NMC Experts Group, monitoring implementation of competency-based medical education, member of Experts Group, UG Medical Education Board, NMC. We hereby invite Dr. John Stephen sir to address the gathering on the topic.
Basically, the story is there's been a lot of change, right? I mean, that was the time, the first black and white photograph is the time when Osler and other people taught medicine, right? But if you see in 2020, this is, of course, we are in 2026 now, a lot of changes have occurred. The type of students have changed, right? The technology has changed. This is technology that's used for teaching, right? And so many things have happened, right? And if I were to go further and say, so therefore, looking at evaluation now is an important thing, okay? So when you first is what to simulate an environment, I think we had a full morning session on that, and Dr. Supe and others gave us a wide spectrum of all the new things that are happening, right? So I don't have to really dwell into this, but you can see a lot of that is there, from standardized patients to computer-based simulations, virtual reality, and they told even more. And it was much more exciting. Why assessment in a simulated environment is the next question, right? Why do we need that assessment? So here, when we come across this, we started with this. But over the years, this is a story of what happened to medical education, right? Osler was the first one who said in the old days when the Osler's time and before Osler's time, the way you learnt and got information was attending lectures like this. There's no other source. There was no material to read from, not much to read from, right? So the only way you did was you went to the lectures and it was a person senior enough came and spoke to you, and that's how it was. Then Osler came in and said, nothing doing. If you don't go to the bedside, you can't learn medicine. So that whole shift from lecture halls to bedside occurred in when Osler came in. After that, all of us know about the Flexner's report. And the whole structure of what we are doing now, for some time now, you have your preclinical years, your paraclinical years. There's 2 years of pre and para, 2 years of clinical, an internship, clerkship. That whole structure came in with the Flexner's report. Okay, Flexner said that you need to understand basic science. If you don't understand basic science, it's very difficult to understand medicine. Okay, that came in somewhere in the 1910. But from 1910 till quite recently, nothing much happened. More or less every country, everywhere, just followed the same thing. Till somewhere we started doing the CBME, and of course now from 2019 we started some change. We brought in CBME. Correct? And times have changed. Now because CBME, you know what happens in CBME, everybody talked about outcome based. So we know this part, right? The core competencies of CBME: clinician, leader, team member, communicator, lifelong learner, professional. Correct? We got that going. So because of this, it was not enough to do our traditional theory paper writing or MCQs, right? You wanted to go further because it demands an assessment of behavioral learning, right? That particular outcome, that particular change has to be, because this is what CBME was all about. And because it demands an assessment of behavioral outcomes, you needed direct observation. How can you talk about behavioral outcomes if you don't have direct observation? You have to do direct observation, right? If you want to do direct observation to say we've reached the objective or not reached the objective, you can do it in one of two ways: on the job, in the clinic assessment, or simulation based assessment. Correct? We don't have any other options. But of course, if you're doing on the job, in the ward, on the patient assessment, you have some problems, right? You won't get the same type of patient. You say they should know something about hernias, and you don't get hernias at all for 6 months. Or each patient is different. Each batch gets different type of patients. It's very inconsistent. It's unreliable. 250 students, where are you going to get that many patients, and time, patient availability? There are challenges. Okay, small group, maybe you'll manage it. There are challenges. So therefore, simulation became an interesting area to look at. It became the important thing. So it's systematic, right? And you can make it reliable. It's the same particular manicure and a lumbar puncture thing that you're giving it is consistent. It's reliable. And you can repeat it. Okay? It's standardized. Patient safety is there. Okay? You're not allowing your undergraduates to go and do something on a patient. Right? Because now we're talking about behavior change, not just about talking to patients. We're talking about procedural things as well. You can't tell an undergraduate to go practice on a patient. Right? So therefore, simulation-based assessments came into the picture. Got that much, right? Now, I want to put something here. Now, I don't know if any of you, I think some of you may have already seen this slide. This is basically a graph of, let us say, for example, the telephone. Telephone is the blue line, right? From the time telephone was invented, for people to start using it, about 90% of the people to start using it, it took about 100 years. Right? It took some time. Okay, initially 30% immediately start using it, but for it to reach that level, it took that much time. You take automobiles. from 20 to 100, about 80 years for about, say, majority of the people to have some automobile. I mean, when you look at our childhood, I know that the first time I went by an aeroplane was only after my MBBS. Okay, so you know what I'm saying. Now our kids are going in an airplane even when they're 3 years old. So, but if you look at that first line, internet, and the second blue line, that is the mobile phone, it's going straight. Okay, the moment the mobile phone came in, internet came in, you know, within about 10 years, most people were using it. And it's the pace at which it's growing. We know that you buy a phone and within 3 months, some other app is there, you can't use the same phone. Okay, and it's changing very fast. Dr. Avinash Supes mentioned so many of those tools that were available, isn't it? And it's quite possible that you start using a tool now and just 4 years from now or 2 years from now that becomes useless because there's something better that is coming. It's changing and changing and changing. That reminds me of when we were in St. John's, we were the first department in dermatology to have a laser. Nobody else had, we had Irving-Mag laser and nobody else had a laser at that time. And we were in fact doing training for other faculty on laser. And then of course St. John's focused not so much in the cosmetic area on care and other things, right? After that they didn't give us any laser. Other hospitals started having laser. And then even the private practitioners having laser, right? By the time we got the next laser, in between we missed 3 versions of the lasers. Okay, so that's what's going to happen to us as well. It's quite possible that some people are already using the tools that Dr. Avinash Supes mentioned, and we may land up after 5 years not using some 100 tools and going straight for the 101 tool. Quite possible. Right? So the thing is, it's going at such a fast pace, we better get used to it. I think we better get used to it and start using and see what's a good thing that's coming out of it. So, assessment in a simulated environment, I'm looking at efficacy factors. So, whatever happened in the morning, whether it was teaching tools, AI, digital, whatever they were talking about, at the end of the day, all of them were tools. Okay, they were all tools. It is for us to find out how to use the tool. There's nothing inherently good and bad about the tool. You have to use the tool appropriately. That's my business, to use the tool appropriately. So I'm going to focus on that part of it. I'm not really focusing on what are the fantastic tools that are available because it may not suit my purpose because it's not feasible, it's not available, it's not expensive and so many other things. But all I'm saying is, everything that was so much so fantastic, so inspiring and all that, at the end of the day, all of them are tools. It's for me to decide how to use them, what to do. So that's what I put it as. If it's an assessment in a simulated environment, there are some efficacy factors. If you want to use it well, you have to look at the efficacy factors. And I put it like this. These are the pillars. If you want to talk about assessment in a simulated thing, there are 10 pillars you have to take care of, right? 10 pillars are there. So let's go one by one. I changed the order a little bit because I want to discuss it this way. So the first one I put as debriefing and feedback. The second one is standardization. Third one is validity. Fourth, alignment with competency. Reliability. Objective scoring. Fidelity, psychological safety, assessor training, feasibility. So if you want to use any of the tools that were mentioned in the morning, in all those sessions, if you want to use any of them in assessment, you make sure you look at all these aspects of that tool. You have to look at these aspects of the tool. You can't use without looking at those aspects. So the first one, we'll go to the feedback part of it. You know this is something you will definitely understand. Authentic assessment, the cornerstone of competency-based medical education. Okay, and I can go about it like this. The key to CBME is what? What's the key to CBME? The most important part. Without that, there's no CBME. Formative assessment. If there is no formative assessment, there is no CBMA. You take formative assessment off, there is no CBMA. Right? What's the key to formative assessment? Feedback. The key to formative assessment is feedback. If you don't give feedback, there is no formative assessment. It's assessment. Correct? There's no formation of anything. There's no formative assessment. What's the key to feedback? Key to feedback is knowing the gap, identifying the gap. You don't know what the gap is, then you can't tell them about that. You have to identify the gap. So if you look at it, if you identify the gap, then only you can give the feedback. Only if you give the feedback, it will be formative. And only if it is formative, it will be CBMA. So it's important, right? So how do you identify the gap? That's the question. No, whichever tool you're using, all the fantastic tools that were mentioned in the morning, you can use whatever tool you want. How do you identify the gap? So if you want to identify the gap, there are 2 points that are there. You have one assessment that is the present level of the student. You have to know the second one, that is the level that you want the student to be in. So that's called the benchmark, right? Now this is okay, anyway, the last one, need to define the benchmark. You got that, right? So you have an assessment here, present level of the student, and that is the desired level of the student. You do an assessment only if you get these 2 points. What is the desired level and what is the level now? Only if you have these 2 points, you know what the gap is. If you don't have the 2 points, you don't have a gap. So if you don't know what the benchmark is, you don't have a gap. You don't know what the gap is, right? If you don't assess in people, there's no gap. So you need both. Only then you can identify the gap. You agree with that? Yeah? So if you look at it, they are the crucial part for identifying the gap. So in a way, if you don't set the benchmark, you don't know the gap. And if you don't know the gap, you can't give feedback and it goes back. So it looks like setting the benchmark also is an important part of the story. So the first one is recognition of the desired goal. That is the benchmark. Who sets the benchmark? We, faculty, will have to set the benchmark. The experts. We all sit together. Of course, all of us have a little bit of a thing on, no, for an undergraduate it should be like that, that should be for postgraduate, that is for MCH. You set a benchmark. That you decide as experts, but you have to do that first. Then you have to have evidence of the present state. That is the assessment that you're doing periodically. You have to have evidence of the present state. You have evidence of his present level, you have benchmark, you have the gap. Agreed? And then understand how to close the gap. So the key word in the third statement is also important. I told you 2 things that are very important. The benchmark. If you don't only know the benchmark, you will know the present situation, the evidence of the present situation. That's the second one. And you identify the gap, and you have to understand a way of closing the gap. That understanding a way of closing the gap is also important. I'll come back to that a little later. So when formative assessment is there are 2 things that are important. It's all related to the gap. Correct? Identifying the gap and providing the feedback. 2 things. So if you want to discuss and get into detail about formative assessment, you have to talk about 2 things. Identifying the gap and providing feedback. Agreed? But if it's summative assessment, you're worried about the validity. Summative assessment is essentially for, let us say, certification. Tomorrow, that's a debate that you all had. Is it good enough to go into and practice medicine? Can I, he did, in the skills lab, he was able to do a venipuncture or collect blood in a task trainer or a simulated mannequin, right? He was able to do that. And can you say that means he's okay to go and collect blood from a 1-year-old baby? That's a decision you have to make. That's a decision you have to make. So because he's okay with the clinical skill gap, so is it valid? Is the test valid? The test the assessment that I'm doing in the skills lab, because he's able to collect blood in an adult mannequin, can I say he should be able to collect blood in a 1-year-old child also? That is validity. So if you're talking about validity, does it measure what it actually is supposed to measure? So the type of assessment will determine the type of gap, or the type of gap that you want to identify, you'll have to decide. For example, if you're talking about a gap in knowledge, there's so many ways to identify that, right? If you're talking about a gap in psychomotor skills, you have to choose a different sort of simulation or assessment. Leadership skills, team skills, you have to have a different checklist. One will be observation, one will be checklist, and it goes on like that. Now, when we talk of validity, demonstration of learning in visual simulation is the shows. Performance in real life, that is what happens in real life, right? So that there's a difference between shows and does. How close is shows and does is what is validity. If you can, what you assess as what they show is very close to the performance in real life, then it's sort of more and more valid. That's what we are trying to figure out. You got this much? Yeah. So if you look at assessment, you know the assessment, informative assessment, you note salient performance gaps, you provide feedback, investigate the basis of that gap, you understand the gap and help close the performance gap. Summative assessment, you collect data. Then you analyze that data. Is it close to a performance and clinical thing? You summarize the data and decide on the competencies. So in summative, for him to be able to conduct give an IM injection for a child, you may have to collect information from his communication skills area, from his theory area, from his skills lab area, and say, put together and say he's okay. Now I'm just going to touch upon feedback, and I put in brackets debriefing. Anybody understands the difference between feedback and debriefing? Any thoughts? Debriefing is a term usually used for much more, like in simulation, simulation areas. Debriefing is what we do for simulated areas. So I'm going to that level because if we have that understanding, the rest of it for task trainers and other things, it's the same thing. Now debriefing, there are some steps. Like I'll give you an example of what will happen. You put a group of people in a skills simulation lab. Let's say 4 of them. One is a nurse, one is the doctor, a senior, the doctor who's the lead. There's an assistant doctor and another student. You put them in and you take them into the room, and that whole process is recorded, and you have a scenario. Okay, let's say somebody suddenly has sudden shortness of breath. Okay, and the BP is falling or the oxygen saturation is falling. That's a scenario. You have to do something about it. You have to evaluate and do something about it. It goes on for 3-4 minutes, and then you look at that video, look at what happened in that room, and you discuss that outside. That will be debriefing. So for that, creating a context for learning, you have to create a context for learning. What I mentioned just now is acute care. How do you manage something in acute care? Maybe you can look at it from the perspective of leadership. You can look at it from the perspective of communication. You can look at it from the perspective of whether the right diagnosis was made in that full tension and panic. That's all up to you. So create a context of learning. Clarify the debriefing process. When you have debriefing done, or even for a task trainer, you have to tell the student what is planned and why. For the next thing, I'm planning the session. It's a 3-minute session. The objective of the session is this. We are looking to see how you work as a leader, how you call upon your strengths. This is what I'm going to do. I'm going to give you a scenario. You have to tell them about what's going to happen and set that. Create psychological safety. Absolutely important, because when you go into these things as scenarios, the student may be very scared of you. Okay, they may be scared that you're going to comment in front of everybody. You're going to tell them all the wrong things that they did, make fun of them, and all those things are going, so many things are going in their mind. They're all students, right? You're doing it in front. So you have to take care of that part and say, I know you're interested in learning. I know you're going to be a good doctor, you've done well. This is nothing to do with pass and fail. We go through that, we'll see where we can improve. You have to make them safe. Only then that performance gets value. So that's a very important part, creating psychological safety. Articulating assumptions that actively support. You have to, the person being, the student, whoever it is, PG or UG, has to feel that the doctor trusts his intention. Okay, you have to say, I know when you want to learn. I know you're going to practice the skill and you come here to learn the skill. So you give that positive vibe. Then have an objective in mind. I told you, the objective can be to evaluate leadership or communication skills or clinical skills. You have an objective in mind and there's a debriefing process. You remember in the gap I said you should understand the gap. In the debriefing, you have to understand the gap. Debriefing process. First you put the video and ask the leader and say, what do you think? How do you think you performed? What went wrong? You ask them for the perspective. Then you tell them, see, this is what happened. Why didn't you do that? And he begins to explain that. Okay, so the first one is get the reaction from them, from the team. Second one is you analyze that phase back and forth and then summarize the whole thing. It's almost like how we do 1 minute perceptor and mini CX and other things, yeah? For example, I told you this situation. Let us say in that particular scenario, the scenario was acute shortness of breath and decreasing oxygen saturation. And when you do that with a little more story there, it's quite possible that the student may think of all the differential diagnosis. You don't know. We have one script in our head. The moment you say shortness of breath, 5 things fall into your place, right? We know from past, from the reading, we have a script. Here they call it frame. He frames his diagnosis like this. It's a frame. In that frame, the 2 things that stand out for him in his own learning, is tension pneumothorax or airway obstruction. These are 2 things that are coming into his frame. Then he looks at other symptoms, history and all that, and maybe he can frame it in one of 2 ways. In one frame, he's looking at tension pneumothorax as the top. In another frame, he's looking at airway obstruction as the top. It depends on what information he's got, what information is gathered, how he's analyzed that thing, right? So when you identify a gap, you're not going to say this is a wrong diagnosis and leave it. You're going to analyze the frame. You're going to discuss with them this frame and say, why did you think of tension pneumothorax? Why did you not think of this? And you have to discuss that frame. You know, so in the debriefing, it's not just telling them that you did well or you didn't do well. It's a little bit more than understanding what made them decide this. Why did he not communicate with the other person? He says, I panicked. You have to understand that he panicked and therefore it didn't do. It's not that he did not know. So that's analyzing the gap is a very important part of it. Now let's look at this. Trauma team trying to manage the patient with a gunshot wound. This is a scenario, okay? I've given 3 types of feedback. Okay, 3 types of feedback. Which feedback do you think is good? First feedback, overall score 7 out of 10. That's all I'm telling you. We write and say 7 out of 10. Second feedback, your scores are in clinical competency 8 out of 10, attitude 8 out of 10, leadership 5 out of 10, communication skills 5, outcome 5 out of 10. The third type, as the patient feedback is, as the patient abruptly decompensated and then lost vital signs, Andre, I didn't hear an explicit statement of what could be causing it. Either a tension pneumothorax or massive blood loss. And what's the team's immediate priority should be. I'm concerned that not stating a plan may have contributed to the delay in decompressing the chest. It looked to me like the team did not focus on the single high priority action. Okay? So he's discussing that and saying, you did not mention this to your colleagues. But the answer that comes back is, people who've done this many times, they should have known this. But then that's what he points out. I hear you saying that attention hemothorax seems like the obvious thing to focus on. Yet as I watched the case, I saw team members working on many other tasks and not decompensating, and whenever the patient died. Okay. So why I put these three things is, when you talk about feedback, it is not about saying you did well, this is good, you forgot one step. It's not that alone. You're trying to understand the gap, understand why the gap occurred. Because it's a formative assessment. You have to form the formation of the competence. You understood that. Okay, so I won't dwell on this too much, but we can discuss debriefing for another session. So that's debriefing done. Next one is standardization. Okay, very, very important, standardization. Standardization is essentially to do with the benchmark. Standardization is to do with the benchmark. All of us need to agree on the benchmark. That's standardization. For whatever tool that you're using, standardization is that. For example, this checklist, okay, I put this checklist and this side agrees with it, this side doesn't agree with it. Now you have to standardize it. You have to bring a consensus there. There are many ways of standardizing it. And so there's normative way and a criterion based way, but all those things are actually standardizing the thing. And in fact, what Sheshadri's session was, that he feels that the standard should come down and we are keeping it high. But that's standardization. You have to standardize it. Somebody has to decide what is that level. If you don't decide that, there is no assessment. You have to standardize it. Okay, simulation should be developed and criteria chosen appropriate to the level of the learner. For example, the one that is there, the checklist, maybe for an undergraduate. A postgraduate in pediatrics, you may want to add something on maybe. I don't know. It depends on the experts. Okay, that's standardization. To rank or not to rank. Okay, because we are talking about formative assessment. It has nothing to do with the rank. So you define a benchmark and say, this is what he has to do, he has to cross that benchmark. There's nothing as grades to say he's a little better than the other one. No. This has to be done. Is he able to do it? Of course, the quality of the benchmark, it depends on the learner, which learner, UG, PG. Sometimes I don't know whether India will bring it up now. After every 5 years you have to renew your license, you have to do a test. If you have to recertify, then the benchmark may change. Assessor aspects, don't you think the faculty need training in all this? I will give you the same checklist and each of us will not know how to fill it. I may do it differently. So assessors have to be assessed. Programmatic aspects, needs and resources will determine. Some things may be available, some things not available. So if of the 10, 3 are not available, what do you do? Do you do an additional method? Those are program aspects. Modalities, do you use standardized patients? Do you have to train the standardized patients? All those things come into the thing. The assessment tool, choice of the tool as well. So standardization is, you have to get that right at the beginning. If you have a simulation lab, you have a skills lab and you're using simulation for evaluation or assessment, you better focus on standardization, get it right and do it better. Sorry. I don't know how to go back. Anyway, this is about validity. I told you, competence and performance. In Shozhou, in the skills lab, you're looking at competence, they're showing you, but the question is he going to be performing in the same way in real life? Just because he did that at the skills lab, how confident I am that he will do the same thing in real life, in a real situation, in an emergency, in a very safe environment, only looking at one plastic limb, he is able to get that IV line. In an emergency situation, in the casualty with 25 patients and people running around and there's no nurse involved, will he be able to do it? So there's a lot of differences. So the thing is, you have to define this validity. How do you say it's valid or not? Now that's what I was telling, I think we may have to start moving there. How do we look at validity? And that is one area there's a gap. We may want to do that. One is comprehensiveness and reliability. Comprehensiveness is that in order to be able to put an IV line for a 1-year-old involves not just a skill of finding the vein. It's about how you handle the children, how you handle the mother, how do you communicate with the mother. It has to be a comprehensive package there, right? And it should be reliable. I just talked about generalizability, that because he did it in the skills lab, do you mean he can do it in the real life? That's the sampling of different clinical scenarios. Now, the moment you start using skills lab and you give them 3 cases, one is an RS case, one is a CVS case, and then you say he's competent to do general medicine, or should we have 5 cases and 5 cases and CNS case, or should we have another 10 cases? Now that's what we're talking about, saying it's like sampling in any research method that you want to do. How many bits in the blueprint that you want to say he's competent, okay? And overall safety as well. So there are a lot of things to consider. For validity, there are different scores. I just thought I'd bring this one name in, because if you are doing some studies and you want to validate your own tools that you're using, there are some scales are there. They look at content, fidelity, internal structural reliability, standardization scenarios, consequences. Sometimes the student will be able to perform beautifully in the skills lab but unable to perform in real life. The reverse also is possible. Because of the way he's being scrutinized in the skills lab, he fumbles. But in real life he's doing it well. That also is possible. So there is our systems to find out of validity, but if you're talking about summative evaluations of pass and fail, the next comes in or something like that, the validity becomes extremely important. Validity, certification, validity becomes important. Alignment with competencies. And a lot of the discussion that we had so far, some of the things that came is aligning competencies. I'll just give you one example of assessment tool selection template. Now, for example, this is what I mean by alignment of competencies. Now here, who gets a simulation? Surgical postgraduate year 1 to postgraduate year 2. That is the level that you looked at. Professional levels we saw. What is the learning goal? A central venous catheterization placement. Which CVC placement will you teach? US guided IJ, that I suppose internal jugular or whatever placement. Ideal performance, according to the thing, within 15 minutes it has to be done. That has been the benchmark. Then by which passing measures? Learner must make fewer than 3 needle passes. Learners must demonstrate successful location and cannulation of vein in the first try. Okay, this is defined by the experts. This is the benchmark. This is the standardization of sorts, right? And which simulation modality you define what particular simulation that you're using, and choose assessment tool type with a checklist. Now, if you write this checklist template, in some ways you are doing that, so that alignment should be there. You want to know what is the competency that you're testing, and then you fill this up. Then you will align what objectives are there, and then the tool and the checklist and other things should be aligned. So that's very important. So if you're going to start using assessment simulation and for assessment, you have to do this. You have to do this. How do I go back? So that's reliability. Now then next one is of course objective scoring. Objective scoring, basically you're talking about cutting off the errors, right? It has to be objective. The subjectivity you want to remove. And we know this from other assessments, all the different ways in which examiners have those errors that is there. So this is particularly in the skills lab setting, okay, quite often, even though you're going to have a checklist, I'll show you some checklists, each of those lines still have some subjectivity there for you to say. It's not like totally it was objective. So there's a lot of training that you have to do. And there's something called rater error training. Focus is on avoiding rater errors and biases. That's one training you're supposed to do. Tell them about what type of errors are there, what are the biases. Focuses on defining performance dimension training, defining skill dimensions. Okay, frame of reference training, focuses on discriminating between skill levels, different levels within that particular line. Rate error rating, reduces occurrence of rate errors, refine. So essentially, this is an important step. You can't let this go, arrange everything else, and this goes wrong, then you got everything wrong. So you can't say, okay, 3 of us are, no, training involves everybody who's going to be involved in the. So therefore, you can first try it out within your institution, but if you're going to do it as for summative exam, for example, then the whole university people have to get involved, because external examiners are coming, then they have to go through a BCME like rater training, only then they'll be eligible to be a assessor and things like that. Over a time, same observer, this is for reliability, scores the same videotape scenario 2 different times and see if it matches, and across multiple raters. So there are some systems of how you can calculate this. Okay, we go and go there. Now fidelity. Now these are some of the checklists that we know. It could be the usual yes/no answer type checklist, and that is something that anybody can use. There's no subjectivity there, so less subjectivity there. You can have like a global rating scales. You have behaviorally anchored rating scales. So for every scale, you define what sort of a behavior you would put this into. Okay. And Likert scale, you know this part of it. In that you can define meets expectation, and there are different scales which has to be defined, and that's the benchmark. I will go there. So the next one is about fidelity, and I think this was touched upon in the morning. And for the first one, let us say, fidelity describes the extent to which a simulation represents reality. Right? Now if you look at case vignettes, you can write a case within 3 lines, but you can give a more descriptive thing so it seems real. Okay, that they have to get the information from the case scenarios. Okay, procedural skills in a well-functioning role play. I mean, role play, we do role play on the stage, right? Where the same students come with a lab coat and take off, and they just do a role play, pull a chair and do that. That also is a role play. But they can play the role, they can actually dress up like a doctor, that can be dressed up like a patient. The whole scenario can look like a clinic, and the patient can look like a patient. Now that becomes a little more real, okay? And you can go on and make it more and more real. So that is what this is all about. And there's see, for example, this is for subcutaneous injections. There was a training in which we use oranges, okay, subcutaneous. That's also a skill lab. But is it real? How real? Now you can use part-time trainers, task trainers, or that's, so you can see now how real is good enough. That also has to be decided. You can use general practice consultation rooms. In fact, there are some high fidelity mannequins, portable mannequins. What you do is you put that mannequin in one of the beds in the ICU, and connect all the respirator, connect everything, and the parameters start working. You go on rounds and you come to that thing, and the scenario starts there in that station. That's making it even more real. Okay. So in fact, the one we have in St. John's, that's possible. Okay, you can take that mannequin and put it on the road, a trauma mannequin, and it could be like an accident. So you could take them to a situation like that. So fidelity is about making it real, and whether that sort of a thing occurs. So of course, psychological safety, I told you about assessor training and feasibility. I mean, you should have those mannequins, you have enough of training and other things. So my point is, there are some reliability factors, the 10 reliability factors. If you're looking at assessment in a simulated environment, you have to take care and spend time on all the 10. Even if one of them is weak, the chain will break, okay? And you can't have even one link which is not there. If that one link is not there, the chain is broken. So you can't say I have a high fidelity simulator I'll start my evaluation. I don't have rater training, doesn't matter, I'll start my evaluation. No, it doesn't work like that. You have to have systems of developing standards, checklists, training, and all those 10 things, and only then there comes on. Okay, so I will end with this. Thank you.
Thank you, ma'am.